All right, let's talk about or go over a case study of an acute lateral ankle sprain with an athlete who we're going to get back to play in less than a week without tape, without brace. And we're talking about a grade 2-3 lateral ankle sprain. And I'm not going to go into clinically the specifics of what I did with this athlete. What I want to talk to you about is the expectations and what we're supposed to do and what athletes expect and what physicians and athletic trainers and PTs tell patients about ankle sprains and other injuries and how screwed up this model is. So we're not going to get in the weeds of what I did treatment-wise. I'm going to kind of go over that on a high-level scale, not into the details. But think about what my thought process is and how that's different than what you were taught in school, because what you were taught in school last year was what they taught in school 10 years ago, which is brought forward from what they taught in school 20 years before that. And what physicians and athletic trainers and PTs tell their patients about injuries and recovery and all that stuff now was brought forward from expectations from the broken medical model years and decades ago. So basically what we're doing now, expectations-wise and return to play-wise and treatment-wise and thought process-wise, is all built off of the faulty thought processes and limited expectations of the past. Okay, so think about what you would do with this athlete if they showed up in your clinic with your prior experience, what you've been told and what you see in the clinic from other people that you may be working with. All right, so we've got a football player, high school football player, grade 2, grade 3 lateral ankle sprain in a game on Thursday night. Sees this happened in the first quarter, so goes into halftime. Physician who is on site comes in, checks out his ankle, and does the typical, "Oh, yeah, you got a really bad ankle sprain. Make an appointment with me in 2 weeks. Up until then, stay off of it. Put it in a brace, wrap it with an ACE wrap, but don't do anything. Be on crutches for the next 2 weeks." Pretty typical. Okay, so I'm thinking that's what you see and what you hear from the medical community. So when I was in PT school, my research topic study was on the treatment of acute lateral ankle sprains. Really bad idea as a student to try to treat that, because guess what? We couldn't get lateral ankle sprains. So our patients were supposed to be less than 48 hours injury. After a year of data collection, we had 4 patients. Why? Because when patients sprain their ankle, what are they told by their parents? What are they told by the athletic trainer? What are they told by the physician? 2 weeks on crutches, don't put weight on it, wrap it, tape it, whatever. Come see me then, and then we'll start therapy. Okay? What did I do with this patient? So I was coaching at the time. I was in the locker room. I looked at him at halftime before the physician did, and I said, "We're going to get you in tomorrow. We'll have you back to play next week." Why did I do that? I'm going to go over that and break it down why that's different than what the physician told him, okay? So the physician is going from a physician standpoint where I am the physician and this is what I've been told and this is what we do in medicine and this is just the way it is and it just sucks to be you because there's no other alternative. My standpoint is this is what I know about physiology. This is what I know about your mechanism of injury. So I know the mechanism of injury because I saw the play happen. Physician didn't even ask him that. I'm going to do a functional evaluation rather than just move his ankle a little bit and say, "Oh, it's swollen. You got a grade 2, grade 3 sprain. You can't play with that." I also understand that ligaments are secondary stabilizers. Primary stabilizers are muscles. So what would happen if I could get the primary stabilizers to engage and do their job and take pressure off of the tissue that's only the secondary stabilizer? Could they heal faster? Would swelling go away faster? Could they return to play even though the ligament hasn't fully healed? So when he returns to play 7 days from now, without a brace and without tape, I'm not saying that his ligament is 100% healed, but what I am saying and what I am going to do is make sure that functionally the primary stabilizers are doing what they're supposed to do in order to keep the secondary stabilizers from having inappropriate pressure put on them. Okay, so what I'm going to do with this guy is I'm going to say, so this is Thursday night game. I told him, you're going to come in tomorrow at lunch so less than 24 hours. Come in tomorrow at lunch, we're gonna work on this, okay? So old school thought process, tissue damage, we need to wait for tissue to heal, and the only way to do that is to rest. Does rest heal anything? No. Okay, so the reason why ankle sprains take forever in the first place is because we wait 2 weeks to see them. Then we have to battle pain. Then we have to battle swelling. Then we have to battle guarding. Then we have to battle more inhibition, which causes more compensation. So now we've got this big ball of crap that we have to deal through, rather than taking it in the acute stage where the only thing that we have is acute swelling and acute pain, which I can get rid of really easily. Okay, so what I'm going to do is have him come over to the clinic at lunch on Friday. I'm going to assess him for function, find out that he's got a lot of swelling. I'm going to assess him for neuromuscular function, find out not doing so sweet because I need to find out what wasn't working that allowed him to roll his ankle in the first place. Then I'm going to have to clean up all of the inhibition that's caused from swelling, because swelling is one of the things that causes neuromuscular inhibition. So I clean up all that stuff. Then what am I going to do? I'm going to do BFR, because I know that BFR is going to help pump that swelling out of there, and I know I can put pressure on it with less resistance, but still get the muscles to react like I'm using them normally with more resistance. So I'm going to go through 180 assessment treatment first. Then I'm going to get him off the table. He's going to walk and say, wow, that feels a lot better. I'm going to put the BFR cuff on him. We're going to do squats. We're going to do lunges. We're going to do heel toe raises. What else did we do? I think we might have done some straight leg deadlifts, something like that. Okay. And then I'm going to see him at practice. So before practice, I'm going to take him into the training room before the trainer gets there, because she doesn't know what the hell I'm doing, and she thinks that he's supposed to be on crutches for 2 weeks. We're not going to talk to her because she is working for the physician that wants to see him in 2 weeks. Okay. So I get him into the training room before practice, 180 treatment there. Tell him to go out to practice, walk around, just do normal stuff. You're not going to do anything today. And then as we go, so then the next day I'm going to see him after school. We're going to do BFR again. We're going to refacilitate again. So I'm going to see him, okay, so that was Friday. So I saw him Friday. Saturday, saw him again after films. Then I saw him Monday. Then I saw him Wednesday. Then he played on Friday. So I saw him 4 times in the span of 7 days. He went from maximal swelling, inhibition, guarding, stiffness, to walking normally on Monday, to returning to practice with tape on Wednesday, to playing on Friday without tape or brace, with no swelling, no inhibition, no guarding, played fine, no issues. Now, he also, important thing here, he also, from that time until the rest of the season, so this was probably like the 3rd game of the season, from that time to the rest of the season, guess how many more ankle sprains he had? Why? Because I got to the root cause of what caused his ankle sprain in the first place. Now let's rewind and see what the broken medical model would have done. 2 weeks on crutches, 2 weeks in a brace, 2 weeks non-weight bearing. Then you go to the trainer who doesn't know what she's doing. So she's going to do ice and give him a TheraBand to do monkey crap in the training room. He's going to be out for another 2 weeks just trying to get back. So now he's missed 4 weeks of his senior year. Now we're butting up against the playoffs, and we're hoping that he can go back to practice now with tape, with a brace, and do all that crap. So the physician and the athletic trainer would have cost this kid his entire senior season, whereas I got him back, and the only thing he lost was 3 days of practice. And he never sprained his ankle again because I got to the root cause. So my bet is, as he left high school, went to play in college the year after, he probably, actually I know this, in lacrosse season, he was still taping his ankle, or he would have been taping his ankle and still having problems, and then had problems going into college because the athletic trainer and the physician would have focused on what? Get rid of swelling, get rid of pain, get range of motion back as you can, get strength back as you can, but he's got a really severe ligament issue, so that's going to limit everything, so he's going to need to be in a brace and tape. So they would have not only cost him his senior season, they would have limited his lacrosse season, and then he would have chronic issues leading up to college. Okay? Broken medical model, chase symptoms, take expectations of the 1980s, 1960s and live by those expectations. 180, get to the root cause, solve the root cause. You don't have to put up with symptoms. They get back to play and do everything they want to do. Okay? So think about that when you have patients coming in and they tell you they have XYZ and they've been told it's going to take XYZ weeks, months, years, whatever to recover from that. And think about where that information came from. That information came from the expectations of the broken medical model last year, a decade ago, 4 decades ago. Why are we doing that? Why did you go to school for 7 years to learn anatomy, physiology, neuromuscular physiology, biomechanics, all that stuff, which is what you should be using, but they didn't teach you how to use that. They also didn't teach you critical thinking, so you didn't ever think about, what does a ligament do? How does that relate to what muscles do? How does that relate to the biomechanics and tissue healing? So his ligament healed 10 times faster than it would have following them, even though I would say that when he returned to play a week later, that ligament wasn't 100% healed, but the primary stabilizers were healed, which allowed that ligament to heal 10 times faster than he would have had if he followed the broken medical model. Okay, so think about what you're doing, where that information came from, where those expectations came from, and should you be doing something different, that's something better that will actually work faster and have longer lasting results to get your patients functionally better without chasing symptoms and wasting your time and their time. You got questions, hit me up and let me know. See you next time.